in general, then, Dr. Koff, how is DLBCL treated?
So in general, for patients who are getting their first-line therapy, they will receive some sort of combination of chemotherapy and what we call immunotherapy. For the vast majority of patients who are young and otherwise healthy, this will be a combination chemotherapy regimen known as R-CHOP, which consists of what I call conventional chemotherapy drugs, an immunotherapy called rituximab, and a steroid known as prednisone.
Wow. What are the main factors you take into consideration before a treatment approach is decided on? You mentioned age, health.
Yes, so I divide it into three different categories. The first category is the patient. So there are patient factors that determine what treatments the patient is able to tolerate. And some of the main factors you mentioned are items like age, or what we call co-morbidities, which are other health problems that the patient may have. But there may be other factors as well. If a patient is not able to take care of themselves very well because they're very ill or they're very debilitated, or they're unable to receive certain treatments because they have social factors that keep them from coming to certain centers or from following up with care. Those all fall under that patient-centered bracket. The next factor that I consider are items related to the lymphoma itself. So we've already mentioned factors like expression of different genes or having certain gene abnormalities. Those may play a role in determining what treatment a patient gets. And then the last big category is where the lymphoma is in the body. And this refers generally, if the lymphoma is only in one limited site, then those patients may get fewer cycles of chemotherapy, less time in chemotherapy, and may receive radiation as part of their frontline treatment, whereas patients who have disease in more than one site or spread out across the body may get more cycles of chemotherapy. But also there are patients who have lymphoma in certain sites that requires that we give additional treatment to make sure that the disease in those special sites is treated.
Where do clinical trials fit in, Dr. Koff?
So our goal in treating diffuse large B-cell lymphoma in the first line setting, so in somebody who's newly diagnosed, in most patients, our goal is to cure, meaning that we treat the patient with chemoimmunotherapy, and our goal is that the lymphoma never comes back, goes away and never comes back. Unfortunately, as of today, we're not able to cure every single patient. And depending on what factors you have in your disease, your likelihood that you will be cured with that first-line therapy may be higher or lower. But until we're able to cure every single patient with our first-line therapy, there is definitely room for improvement. And that's where clinical trials figure in, because the way that we are able to tell whether new therapies or new approaches to therapies are improving upon our goal of curing or our goal of controlling the lymphoma, we need to test them very rigorously in clinical trials.
Of course. What about for patients with relapse disease?
So there are several different approaches that we use to patients who have relapsed, depending on a lot of different factors that may play into a particular case. I would argue that in this case, clinical trials are even more important, because although we can still treat with the goal of cure for relapsed patients with DLBCL, the likelihood that somebody will be cured after they've received their frontline therapy goes down, regardless of the factors related to the case. Mm-hmm. And so this is a setting where it's even more important that we improve upon our current strategies of treatment and our current treatments that we have available. And clinical trials, again, are the way that we move forward with this.